to take this opportunity to thank the sponsor for this talk, which is Pioneer Veterinary Products. And just a little reminder that after the symposium has ended today, please do check out our virtual expo. You can get to it through going into the lobby and clicking on Expo. That's got information from all of our sponsors and exhibitors, with lots of sort of information and sort of things for you to sort of click on and have a look at. We also have our virtual goodie bags, which our sponsors have put lots of sort of links and things, again, lots of information for you in there. Most people should have had a link for that. If you haven't, please check your junk mail, but also another bunch of invites will be going out tomorrow, so you might get your link tomorrow. But brilliant. So I'll just introduce Brennan. So like I said, Brennan is also known as SkepVet, and I would encourage everyone to check out his website. Brennan is famed for his online advice, calling out bad science and helping people to determine what's fake news and what is reliable information. In this lecture, Brennan will equip us with the tools to scrutinise therapies that we use already. Some of them might be quite well established. And yeah, really just get us thinking a bit more deeply and questioning what we think we know. But yeah, thanks, Brennan. I'll let you go ahead.
Well, thank you, Jay. And I want to say thank you to Hannah and Paul and everybody who's been involved in pulling this together and having me here, and for everyone who's participating. I hope this is going to be interesting and useful for you. So just to follow up a little bit on who I am and why in the world you're listening to me, I'm a clinician, a small animal veterinarian in private practice. I went to the University of Pennsylvania, but I'm also kind of a nerd, and I'm interested particularly in the relationship between scientific evidence and clinical practice. How do we know what we know? How do we know if we're right or wrong on the recommendations we make? So that led me into the field of epidemiology. Long before veterinary medicine came along, I was actually a primatologist. So that's my deep backstory. And in terms of my work experience, I've been in clinical small animal practice for about 25 years. And as I said, being a nerd, I've been involved in evidence-based medicine for nearly all of that time. I've been a member and a past president of the Evidence-Based Veterinary Medicine Association. And in the last few years, I've actually gotten involved with a company called Loyal, a biotechnology company. We're working on trying to develop prescription medications to extend healthy lifespan in dogs. So I'm in the biotechnology and longevity field now, which is not a turn in the road I was anticipating. And then, as mentioned, I am known or infamous, depending on your perspective, as the SkepVet, trying to provide science-based pet health information to veterinary professionals and pet owners as well. So when talking about treating arthritis, I like to start at the very beginning so that we're all kind of thinking of this in the same way. What is it we're actually trying to accomplish? What's the goal in osteoarthritis treatment? And the goal, I think, is to improve quality of life. And that has a number of elements. Obviously, we want to reduce pain because osteoarthritis is a painful condition. So alleviating pain is part of what we're trying to achieve. And we want to improve the function of our patients. Not only the most basic level of function, standing, walking, but what in humans is often referred to as activities of daily living or an instrumental function. Being able to get up and go out and go to the bathroom when a dog wants to, or being able to make it to the food bowl, or follow the owner around the house, which is really important to a lot of our canine patients. Some dogs even have a higher level of integration to their function. They have a role as a service dog. So improving function is a really important goal for improving quality of life when we're treating this disease. And with my interest in longevity, I would say one of our goals may actually be to extend lifespan. It turns out that musculoskeletal disease, and osteoarthritis is the most common of these, is one of the top causes of death in dogs. It's a very important life-limiting condition. And it is life-limiting in the way so many conditions are for our patients, not by itself, but because it leads to a deterioration in quality of life that requires us to make the difficult decision to euthanize our pets. So we are improving quality of life by improving pain, by improving function, and potentially doing so extends the life of our patients. So who are the players in this therapeutic relationship, and what do each of them need in order for us to be successful at accomplishing this goal? Obviously, the main participants are the patient themselves, the owner and their family, and the veterinarian. And each of us in this relationship have a different set of perspectives and needs and goals. So the patient essentially requires effective treatment. The patient wants to feel better, to have less pain, and have better function. And that treatment has to come with acceptable side effects. I'm a firm believer in the idea that almost nothing is free in physiology, that anything that has a significant benefit has some potential adverse effects. And we need to make sure that those are acceptable, that the benefits exceed the risks, and that we're not we're not compromising the quality of life for our patients by trying to treat their disease. Now, owners need treatment that appears to them to be effective, which is not to say that they don't care that it truly is effective, but unfortunately, owners don't have a direct line to how their pet feels. They have a very strong ability to observe them in their day-to-day life. They have a very deep relationship with them. So I think they really have a good insight into what quality of life is like for their patients, for their pets. But the reality is that there is a placebo effect for humans, and it is possible that a treatment will appear effective and that will be satisfying to an owner, even if it's not truly effective. And that's a pitfall that we need to watch out for. The treatment also needs to be acceptable to the owner, and that means that their perception of the risks and the benefits and the relationship between the two makes it seem like a worthwhile treatment. It has to be accessible or affordable. That's a very important aspect of what we do in veterinary medicine. It has to have a burden on the caregiver that is not unsustainable. If you have an aggressive dog that needs to be medicated frequently with oral medications, that's a barrier to being able to effectively employ that therapy. And to some extent, there needs to be a philosophical alignment between the therapy and the owner. And I'll talk about some examples where, a therapy that I would judge as effective isn't practically effective or acceptable to the owner because of some differences in philosophy. What do we need as clinicians in order to effectively achieve the goal of a better quality of life for our arthritis patients? Well, we need knowledge. We need to know what the treatment options are, and we need to really understand in a sound, evidence-based way what the risks and benefits of each of those things are. We also need the capacity to offer the treatments that we think will be beneficial to our patients. So we need to have the training, the skill set, the time, the staff, maybe the equipment, all of the things that are necessary for us to be able to offer a treatment to our clients and our patients. We also need an effective veterinary client-patient relationship, and that involves communication skills and empathy and the ability to understand what the other players in this relationship think and feel and want in order to make sure that we come up with diagnostic and treatment plans that are effective and accessible. So we need to know what the client's goals and values and perspective are. We need to know what their limitations and their capacity is so that we don't push on them treatments that are not practically useful or acceptable to them. We need to be able to communicate effectively. And I would argue we have an ethical obligation to provide informed consent. So we need to use our knowledge to give accurate information that is understandable to our clients so they can make choices about the best therapy for their pets. I do think we also need to understand the patient perspective. And that's an interesting one because obviously the client understands it from one perspective and we understand it from another. The client has a personal relationship with the patient, and that gives them an insight that we can't have. We, on the other hand, have a base of scientific knowledge and of experience as clinicians that gives us a perspective on what the patient needs that the client doesn't have. And as we all know, sometimes there's not a good alignment between those perspectives, and that can be a barrier to good quality care. What are the barriers? When do we run into trouble at achieving our goals in managing arthritis or any other condition? Not having enough choices, not having enough options. We've had some new therapies come into this particular field recently that we're all excited about because we are aware that our options are limited and they don't necessarily meet the needs of every single patient or client. We also have options, I think, that are not effective, things that clients may choose to use for themselves, or even things that we may offer as clinicians that don't actually achieve the goal of improving pain or improving function. And that's a barrier to achieving that goal if we're employing therapies that don't actually work. We always have an insufficiency of information and evidence. I like to tell people when I'm talking to folks in the human medicine world that we're in veterinary medicine, we're kind of the poor country cousin of human medicine in terms of the availability of evidence and information and resources to do research. So we're always short of information. And sometimes the information we do have doesn't get to where it needs to get, doesn't get to the clinicians, or it's not translated effectively for the public. And then there's misinformation. There's a ton of information that is accessible to us and to our clients that's actually wrong and misleading. And that is a barrier to effectively achieving our goals of treating osteoarthritis. This is where evidence-based medicine comes in, and I'm a big fan and a proponent of this, and I think this is a set of perspectives and tools that can make a real difference in our lives as clinicians. And as I've said, I've been a private practice small animal clinician for many, many years. So I don't believe evidence-based medicine is just the purview of academics and researchers. I think it is very much a useful set of ideas and tools for us in the trenches in real-world practice. As a quick reminder, what is evidence-based medicine? It is the intersection between several important aspects of how we understand and manage health problems. It's obviously our experience and expertise as clinicians, which is a valuable component. It is the scientific evidence that we use to develop and understand how our therapies work. And it is what our clients want to achieve, what their values are. It also, I think, involves the patient. It's a little tricky in veterinary medicine because our patients can't necessarily conceptualize and articulate their own feelings and choices about their healthcare, but they can, as we all know, sometimes make their feelings and choices quite clear. And we have to incorporate that into our reasoning. I think where we fall down most frequently in employing this is in judiciously, thoughtfully, intentionally incorporating scientific evidence into our decision making. We tend to do that in a rather haphazard background sort of way. We participate in events like this and we get new ideas and information, but we don't necessarily develop the day-to-day habits that allow us to use scientific evidence as effectively as we could to help make treatment decisions. It's much easier and more common to rely on our personal experience and expertise. Most of you have seen some variety of this evidence pyramid, and this just makes a couple of very simple points. The details are less important than the general pattern, which is that the information that is most readily accessible to us, that is the most psychologically compelling, is the information at the bottom, which is why it's the base of the pyramid. It is our own observations, the anecdotes and stories we hear from others, and that is unfortunately also the most susceptible to bias and error of the information that we can use to make decisions. At the top of the pyramid is all of this really fancy meta-analysis, systematic review, all of this stuff that the smart people in academia do to help us in the trenches to make decisions. It's the synthesis of large quantities of high quality research information. That is certainly the most reliable and useful in many ways. It's also the hardest to come by and the most scarce in veterinary medicine in particular. So our way of thinking about evidence is really not so much about the details as just understanding that not all evidence is created equal, and our confidence in the conclusions we draw should be related to the different levels of evidence. And I'll talk a bit more about that in a second. Here's sort of what I think of as a very simple, quick and dirty way of using this idea to evaluate any therapy that you're considering. You want to ask yourself three questions. Could it work? Might it work? And does it work? And there are components to each of these. Could it work is about what we call biologic plausibility. Does the explanation for a therapy and how it works seem consistent with established science, with what we already know is likely to be true based on all the other things that we understand about biology and physiology and chemistry, right? Does it make sense? Could it work if what we know is correct, or does it require everything we know to be wrong in order to work? Might it work is all of the basic preclinical research. So what do we understand about the chemistry of a drug? Or what do we understand about the physiologic response to some kind of a therapy? Does it work in vitro, in cells? Does it work in animal models? And of course, the most useful animal model for veterinary patients is the human, right? Because there's a mountain of evidence for most things in humans. But humans are not cats and dogs, and we have to think carefully about how we translate evidence from one species to another. Nevertheless, that's a source of evidence we can't afford to ignore because it's enormous and often very high quality. So what do we know that tells us that it might actually work? If there is a plausible mechanism and it could work, might it actually work? Well, that requires all this other information. And then, of course, the final, where the rubber hits the road, the final question is, does it work? And that involves what we usually think of when we talk about evidence, right? We think about clinical trials, testing specific therapies in the species we're interested in, and ideally doing that with all the right methodology, repeating the trials so that different groups with different sorts of biases and perspectives all come to the same conclusion, right? That's the ultimate source of evidence that we should use. Now, there's lots of other stuff that plays into the question of whether we choose a therapy or not. The cost of it, the risks and the benefits, there are lots of other factors. But in terms of just evaluating the basic safety and efficacy, those three questions will get you a long ways. Now, I talk about could it work a little bit because this one bothers people the most, I think. And people understand the idea of doing a clinical trial to see if a therapy actually does work, but they're not always sure that it matters whether we have a scientifically rational explanation for how something could work. Because science is incomplete and imperfect, and there's lots we don't know. And there are therapies that we use all the time that we still don't entirely understand how they work. So I think sometimes people don't understand why this might be worth considering as one of the pillars of evidence. So I'm going to bring in an example that was invented by a physician, Harriet Hall, who was a great science communicator, passed away recently, called tooth fairy science. You can do some really interesting scientific analysis of how the tooth fairy pays off children for their teeth. And you can look at all of the particular variables you might care about, like, does it matter which tooth? Do you get different amounts of money for different teeth? Or does it matter how old the child is? Does it matter what sex the child is? You can do all of this data collection in an appropriate scientific way. And then you can come up with a result that you can analyze statistically. You can find out that, for example, the tooth fairy pays boys more than girls because the tooth fairy is a sexist, apparently. So boys get more money for their teeth than girls do. Or you can find that the value of larger teeth is greater than the value of small teeth. And you think, well, that kind of makes sense, I guess. But now, wait a minute. Older children also get paid more money than younger children. And we know that there's a relationship between the size of the tooth and the age at which it's shed. So maybe this is confounding. Is this a real relationship? And you can do some analysis to look at that. And you can draw conclusions and you can say, okay, well, the tooth fairy prefers boys and she likes bigger teeth, unless maybe we're getting confused between age and size. The problem with all of this, of course, is laughably obvious, which is that there is no tooth fairy and none of this exists, right? But the problem is that you can do really very scientifically legitimate looking research on things that don't make any fundamental sense. And the data, the evidence that you generate when you do that can only be misleading. It cannot be informative, right? So if you're doing research on the tooth fairy, unfortunately, you've missed one of the key steps in the evidence-based pyramid, which is biologic plausibility. Could it work? Now, there is some interesting research here in the US on the tooth fairy, and this is more on how much parents apparently think different teeth are worth. I found this really interesting, both the state to state variation and also the fact that I was lucky as a child to get a quarter for my teeth. So $4.50 for a tooth is pretty impressive to me, but I must be getting old. So tooth fairy science, are there things that are examples of this in veterinary medicine? Absolutely. I would put homeopathy in this category. The only way that homeopathy can be an effective therapy is if all the basic fundamentals that we know about biology and physics and chemistry are just all wrong. And is that possible in some world? Perhaps, but it seems very unlikely. And all the research that we generate studying that is fundamentally misleading because it's based on a core premise that isn't real. A lot of other therapies fall into this category, a lot of what we tend to call energy medicine, a lot of traditional Chinese medicine, which is based on some pre-scientific folk medical theories about how the universe works that are not consistent with how science currently thinks the universe works. And so if we are choosing therapies and studying them on the basis of this, I think we're heading down a road that could potentially lead us to the wrong place. All right, so the three basic pillars: could it work, might it work, and does it? From a practical point of view, what should we do if we want to practice evidence-based medicine in the real world, in the clinic? We should always proportion the confidence in our conclusions and our recommendations to the strength of the evidence. It doesn't mean that we don't recommend things with low quality evidence. I do that all the time because low quality evidence is most of the evidence we have in veterinary medicine. But I also have relatively low confidence in things that have low quality evidence to support them, and I tell owners about that. Ideally, the confidence that we have in our beliefs and our recommendations should be proportional to the evidence. And you could be at the very bottom where there's absolutely nothing. Somebody simply invented something in their garage for no reason at all that they can explain, and there's no reason to take that seriously. There's no real evidence for it. We can have essentially zero confidence in that therapy. At the other end, we could potentially have very, very strong, consistent, robust evidence at all levels and have high confidence. Sadly, we don't get that very often in veterinary medicine. Gravity, death, and taxes. There are a few things that we can have really solid, almost complete confidence in. But the reality is that the evidence will always have limitations, and our confidence will always have to be incomplete. I think most people think they do this. We already think that we are science-based in what we do, but that's not always true. A lot of times what we do is something a little more like this. We may gradually increase our confidence in something that we already believe in as more evidence appears to support it, right? Or we may have a confidence in our beliefs and our therapies that is essentially unconnected with the strength of the evidence, that is at least connected to our personal experience more than it is to the scientific research evidence. And there is even a phenomenon by which our confidence in something we believe increases as the evidence against that idea grows stronger. This is called the backfire effect. Part of this is because we have a natural phenomenon known as confirmation bias. We seek evidence that confirms our beliefs, and we have a phenomenon known as cognitive dissonance. It's very uncomfortable to recognize that a belief that you hold strongly, that is integral to your whole worldview, is mistaken. And we try really hard to avoid experiencing that discomfort. So those of us in particular who are intelligent and well-educated and deeply involved in a field like veterinary medicine are particularly good at marshaling evidence to defend our beliefs, even if they may actually not be true. So as other people challenge our beliefs, we tend to grow stronger in those beliefs. And that's a fundamental feature of human psychology that makes evidence-based medicine a little challenging. Most of us, I think, are also aware of the caregiver placebo effect. This is simply has been well demonstrated in a number of studies. Simply the fact that we tend to see improvement in patients in clinical studies who are getting placebo, who are not essentially getting any effective therapy. And this can happen in as many as half of the patients for owners, and sometimes a quarter to half of the patients for veterinarians, depending on how we're doing the assessments. The caregiver placebo effect is very consistent. There's no question that it exists. And there are a number of causes for it. I think one of the biggest ones is simply that we see what we hope and expect to see, that we tend to want certain outcomes more than others, and we look for those outcomes even if they may not actually be there. Now, animals in clinical studies also tend to improve objectively to some extent, partly because the natural course of the disease may wax and wane and they may be improving on their own, partly because if you're in a clinical study, you're getting a lot of monitoring and care, so you may actually be improving for reasons that have nothing to do with the study that is this therapy the study is intended to test. But the reality is that this is very, very common. And it's not just common in research studies. The caregiver placebo effect happens every single time I give a patient a therapy. And it may be an effective therapy or it may be a therapy that doesn't work, but some of my and the owner's perception of the effectiveness of that therapy is related to this placebo effect. You cannot extract it from the relationship. It becomes a problem when we think that our patients are getting better, but they are actually not getting better. And in the reality of the world that we work in, we're rarely doing objective force plate measurements or really objective blinded kinds of assessments. So we're particularly vulnerable to this problem. The last thing before I move on to some specifics about osteoarthritis therapies is to talk about how we balance this problem that sometimes we need to do things. Our patients have needs that are urgent, and yet we have uncertainty in the evidence. We may not have a very strong confidence in a particular therapy. And the way I look at this is there are certain sort of care quadrants or characterizations that you can make of the relationship between these two things. You can have something where the urgency is quite clear. Your patient is in a lot of pain or has a very significant medical problem that needs to be addressed. And the uncertainty is quite low. There's really good evidence for whatever therapy you're considering. No brainer. It's easy. You simply do that. And that's the case for a lot of the medications that we use. Not all of them, as you'll see, but a lot of them. You can also be in a situation where you have a high uncertainty. You don't actually know whether the therapy works or not. There's not much evidence. And the urgency is low. You may have a very mildly affected patient that doesn't really require intervention. Sometimes there is a pressure from the client to intervene, and sometimes we feel pressure internally as veterinarians to do something, but that commission bias, that psychological drive to do something may not be justified. And if you're in a situation where the clinical need is unclear and the value or safety of the therapy is unclear, I think it's pretty easy to say, hey, I don't think we should do this, right? Antibiotics for viral infections is a great example. So there are lots and lots of osteoarthritis therapies out there in the world that people are selling for which there's very little evidence, and yet people will often want to use them preventatively before their patient even has any detectable disease or at an early stage when perhaps that risk is not worth taking. Now, if you're in the lucky situation where you have great evidence, so there's not much uncertainty, and you also have a patient that has relatively minimal clinical disease, do what you like. I mean, you'll know whether that particular therapy makes sense. That one's easy. Here's where we get into trouble. Here's where you have a patient that has a significant need and maybe isn't responding to something that you already have that you're doing, but what you have left available to offer is something for which there's not really good quality evidence and you're not really, you can't be confident in that therapy. And that's a really difficult situation. And there's no perfect universal answer to how to handle that situation. I do think one of the most important things is communication with the client. I think it's really important that we be open and honest with clients about the uncertainty in the evidence, and that we help them to understand that they're making a choice based on a certain amount of unknowns. And medicine always has that in it, but in particular situations that can be particularly significant, that we may not know whether this therapy is going to work or not, or even if it's going to have negative effects that we don't want. But if the urgency to do something is high enough, that may be okay, so long as we've had a very transparent conversation with the client about that. So key points: confidence should be proportional to the strength of the evidence. It's usually not. We usually have way more confidence than the evidence justifies in the things that we believe in. Anecdotes and experience are really useful for generating hypotheses. Our evaluation of the world without science isn't always wrong. Sometimes it's absolutely right. It's just hard to know when it's right and when it's wrong without doing the science. So the reality is, of course, that we all believe what we see and experience and the stories we hear much more readily than data. It's just how our brains are built. Evidence, unfortunately, in veterinary medicine is often weak and the uncertainty is high, and we simply have to adjust to that and be transparent with clients about that. And the reality is that if our therapies don't actually work, that hurts patients. It may hurt them directly if these therapies have unanticipated side effects. It may hurt them indirectly by delaying or replacing therapies that actually would work or be beneficial. And it gets clients and veterinarians in the habit of trusting and relying on anecdotal evidence rather than research evidence, because we get used to doing that. And I think that it's understandable that we get used to doing that when the evidence base is so weak often, but I think we have to be careful about that slippery slope. Okay. So what I'd like to do now is shift to trying to apply this method or this approach to some therapies that have been used or are used for osteoarthritis. And I'm going to pick just a selection of therapies, because there are hundreds of them, that I think illustrate sort of different places that you can be on the spectrum of the relationship between evidence and what we're trying to do. The first thing I want to say is, because we know that our personal experiences and the impressions that we and our clients may have about the condition of the patient are subject to bias and error and often unreliable, I'm a big fan of clinical metrology instruments. I think we should all be using objective validated tools as much as we can. They're not perfect and we can still make mistakes with them, but I think they help us. So things like pain scales. I think pain scales are really important. Functional scales that look at what the disease is doing to the dog's ability to function on a day-to-day basis. General quality of life scales, particularly when we're talking about end-of-life decision-making, or about maybe trying things that we don't have good evidence for. Does the impact of the disease on the quality of life justify taking that kind of a leap? And maybe caregiver burden. Maybe we should be trying a little harder to objectively evaluate the impact of the recommendations that we're making on the quality of life for our clients. Because I think we all know that if we make a recommendation that is too high a burden, it's not going to be effective. And the more we know about that, the better we can tailor our recommendations to particular patients. So let's go through some examples of: could it work? Might it work? Does it work? I'm going to start with one that's probably the mainstay of therapy for osteoarthritis for many of us, which is nonsteroidal anti-inflammatory drugs. Not because I think we need to prove that they work, but because I think they're a good example of sort of one end of the spectrum. When you look at the biologic plausibility, we have a very detailed, in-depth, long-standing knowledge of the physiology of inflammation and pain, and that has been successful in developing therapies, so it's pretty well-established knowledge. We know quite a bit about how these particular drugs operate, their risks, their benefits. The biologic plausibility for this particular category of therapies and how they interact with the nervous system to moderate pain is pretty well established. So I think we can have a high degree of confidence in the basic plausibility of this as a therapy. And that's pretty uncontroversial. Might it work? There is an enormous body of research literature looking at the pharmacology, the toxicology, the basic biology of nonsteroidal anti-inflammatory drugs, how they work in vitro, how they work in animal model systems. We know that they are the mainstay of pharmacologic therapy in humans, and there's an even greater body of evidence supporting that. So they are strongly recommended by clinical practice guidelines. This is one thing, I'll take a moment, a digression, to say that MDs are often fortunate in that they are able to rely on clinical practice guidelines, often based on high quality evidence, for making decisions about things. They're also hamstrung in that they are often forced to rely on these guidelines, and it's harder sometimes for them to tailor their therapies to their individual patients. So there's a two-edged sword there. But I will often look at what clinical practice guidelines in human medicine say about particular therapies, because I think that that gives us some sense of how the evidence in humans is being interpreted by experts in the field. We sometimes have these in veterinary medicine, and sometimes they're evidence-based, and sometimes they're not particularly. They're more opinion documents. But I think that the way that we could be going as a profession for it to be easier for those of us in the trenches in clinical practice to practice in an evidence-based way would be to have more documents like this, and obviously a more robust evidence base. So from a might it work point of view, I think the confidence we can have in NSAIDs is quite high. There's lots of good preclinical evidence to support this. From a does it work point of view, we've been doing systematic reviews on treatments for arthritis for quite a few years, and the strongest evidence available is always in support of NSAIDs as a therapy. So we have not as much evidence as we'd like, or not as much evidence as they have in humans, but what we do have is pretty strong and pretty consistent. And most of the reviews of the literature end up with a high degree of comfort or a strong confidence in the effectiveness of these therapies. And I don't think there's too much debate about that. So high confidence in all three domains. Biologic plausibility, could it work? Sure. Basic preclinical research, animal models, what does it look like in people? Yeah, high confidence that it might work. And actual clinical studies in veterinary species, yes, high confidence that it does work. That's what we would love to have for all of our therapies, right? And if we work hard enough, we can get there for some of them, but we're definitely not there for a lot of them. Now let's look at another one that I think most of you will recognize is problematic, and it's problematic particularly for a couple of areas in this trilogy, if you will, of evidence pillars. Could it work? We do know quite a bit about the pharmacology of this drug and how it interacts with pain, how it interacts with opioid receptors and serotonin, all the basic biology. And I think that that's been well studied in terms of the pharmacology of this in general. So as a drug, there's nothing biologically implausible about tramadol as a pain reliever. So from the point of view of could it work? Sure, we have pretty high confidence in the basic idea behind this treatment. Might it work is where we get into trouble, right? Because we know that this is a prodrug that has to be metabolized to the active form. And we've had some evidence for quite some time in dogs in particular that that conversion to the active metabolite is not very efficient and very effective. So we've had several studies that show that that's not happening in the way that it happens in humans, where this drug is widely used and believed to be effective. And that's where the preclinical research throws up a red flag for us, right? That basically it's very difficult to obtain meaningful therapeutic concentrations of the active metabolite in dogs giving this drug orally. So the middle of these three pillars, might it work? I think we have to have fairly low confidence in that. Now, what do we do from that point on? Do we go forward to check, does it actually work? Do we do clinical trials on this? I would say yes. I think it's reasonable to do clinical trials. I think we would probably not pick this as the first thing that we would study if we have limited time and resources to do research. But I think, there's enough plausibility that we could potentially find a way to make this a useful therapy. Do we start using a drug like this widely in clinical practice prior to the development of really good clinical trials showing that it's effective? Ideally, no. Ideally, these red flags at this level should be enough to make us cautious about doing that. In reality, though, that's certainly what happened here in the US. I don't know so much about other places, but I do know here in the US, tramadol has been and still is widely used for osteoarthritis pain, despite these red flags. And eventually, we were able to do some clinical studies, both in lab animal dogs and also in patients, clinical patients, to show that, in fact, it did not do a very good job of reducing pain. And the particular study in osteoarthritis found that carprofen was effective beyond placebo, but tramadol was not, which was pretty much the nail in the coffin for me on using this drug for osteoarthritis. Now, does that say that there's no patient in which it might work in certain ways, at certain frequencies, in certain formulae? I mean, there are always potential caveats to this. But in general, I think what we did is we missed one of the steps and got to a point where we were widely using a drug that turned out probably not to be very effective. And of course, all the clients that I ever gave it to said it worked great. right? Because the caregiver placebo effect is always there waiting for us. Okay, this is just a systematic review looking at the evidence that we have, and this shows that the evidence is not ironclad or perfect. There is some overlap in the potential efficacy of tramadol with the COX inhibitors, with some of the NSAIDs. That is probably a function of natural noise in the data. But I think if you look at, in general, whether we should be using this certainly as a first-line drug, definitely not, and arguably maybe not even at all. So low confidence in the does it work domain. I know that there are some questions. I've mentioned earlier that I'm entirely too old to be good at monitoring the chat and talking at the same time. So hopefully you will all hang on to your questions and I can address them towards the end. Now I want to look at another drug which I see widely used for pain of a variety of sorts, including osteoarthritis and post-surgical pain in practice, which is gabapentin. And I want to go through that same set of steps because I think that there are some interesting issues raised by this drug that are a little different from the other two examples that I've used. So from a basic biologic plausibility, we do have a good understanding of some of the ways in which gabapentin acts on calcium channels to affect, neurotransmitter release. But there are actually some gaps in our understanding of exactly how this drug treats pain, despite a fair bit of research. So I think we have a moderate degree of confidence for some kinds of analgesic effects from gabapentin and related drugs, but I don't think we actually, certainly from the point of view of osteoarthritis and post-op surgical pain, I don't think we have a high degree of confidence. I think we know enough about it to know that it's possible that it could work, but there are some weaknesses in that literature. From the might it work point of view, again, looking at the human data, it is widely used for a wide range of painful conditions in humans. But if you look at reviews of the clinical evidence, there's some concern about that. It's pretty well demonstrated for a couple of very specific kinds of conditions, but the reviews will all say, we're not actually sure that it should be used as widely as it is used. In fact, even though the evidence is pretty good for postherpetic neuropathy, for diabetic neuropathy, even in a fairly high proportion of patients with neuropathic pain, it doesn't seem to be that effective. And for other kinds of pain, for chronic inflammatory diseases like osteoarthritis, for post-surgical pain, the evidence is actually pretty poor, despite the fact that this is pretty widely used in human medicine. The clinical practice guideline of relevance from the American College of Rheumatology specifically refrains from making any recommendation one way or another because there simply isn't enough evidence in humans to tell us whether this should be useful as a pain drug for osteoarthritis or not. So I think, we should be a little bit concerned. We don't have a lot of data yet in dogs. It does show that generally speaking, it's absorbed fairly well, but also eliminated fairly quickly. And you may need to dose fairly frequently to get therapeutic plasma concentrations. This is just an illustration of both the IV and the oral dosing of gabapentin. And you can see that the plasma concentration drops off quite quickly. And we've known that for a while. So again, timing of dosing may turn out to be important here. Overall, I think based on the human evidence and the very little bit of basic preclinical research we have in dogs, I think there's fairly low confidence in the idea that it might work. There's some things we don't know entirely about how it works, and what we do have suggests that very, very specific, narrow kinds of pain are the kinds of things that it works best for, and it's not entirely clear how broad an analgesic it is, particularly for something like osteoarthritis. So I would put a fairly low frame of confidence around that. What do we have in terms of actual clinical studies? Not a ton, but we do have a few. This was a study looking specifically at naturally occurring neuropathic pain, where they used meloxicam as an NSAID as a positive control of gabapentin. And they did not find significant differences in the pain scale they used, the CBPI, between the placebo and the gabapentin. Both improved over baseline because obviously everything gets better in a clinical trial, but the gabapentin didn't seem to do any better than the placebo. Okay, so that's a little bit of a concern, not a direct osteoarthritis trial for sure. There are also quite a few studies looking at it for postoperative pain, and generally speaking, those tend to be negative. Again, this is different from osteoarthritis and chronic pain, so that's difficult to translate directly. But I certainly do know lots of people who are also using this for postoperative pain routinely, largely for the same reason that we use tramadol, because there is what I call NSAIDophobia out there. People seem very, very anxious about using NSAIDs, and so they're very quick to jump on the bandwagon for any drug that isn't an NSAID that might be an analgesic, an oral analgesic, especially for dogs. This is, again, another postoperative study that didn't find any significant benefit. So the data is, not perfect and not exactly what we need yet, but it's not going in the ideal direction. Even with something like intervertebral disc disease, this is a surgical model, but it also could potentially be a source of neuropathic pain. Didn't seem helpful. Now, twice a day, is that often enough? Probably not. So, the evidence in general is not great. This is from the most recent American Animal Hospital Association pain management guideline. And I found this striking. They refer to this as the new tramadol. And that's my concern. I think we so far don't have enough evidence to say with confidence one way or the other if this is a good pain reliever for some of these indications. I think what we do have is fairly widespread use in the face of very limited evidence and a couple of red flags in both the might it work and the does it work category. And with tramadol, I think we had an awful lot of patients on an ineffective drug for a long time. And I'm a little worried that we may be doing the same thing with gabapentin, or that we may be identifying sedation or a diminishing of anxiety as pain relief, which are also potential pitfalls for this drug. All right, the last one I'm going to talk about is the one where Hannah gets the controversy that she wanted out of me. I will say that controversy often depends on your perspective. If you agree with what I say, then what I say won't sound controversial to you at all. If you disagree with what I say, then it may very well sound controversial. But I'm going to talk about acupuncture. And I'm going to start by saying it's really, really complicated. And there is no simple right or wrong answer. But I just want to throw out some things that I think are maybe not always thought about, that could be thought about when we're evaluating this therapy. From a biologic plausibility point of view, there are two ways that you can look at this. You can look at this from a traditional Chinese medicine perspective. And a lot of folks who are trained this way and a lot of folks who practice acupuncture this way refer to their choice of how to treat, what to treat, and how to evaluate the treatment in terms of these basic principles. Things like the vital life force or qi, things like the balance between yin and yang, the elements. There's a theory that just as there were 5 seasons, because the ancient Chinese chose 5 instead of the 4 that we're more familiar with, and those 5 seasons represented the elements, and those elements represented the organs of the body. There are all of these sort of pre-scientific cultural ways of understanding the universe, and every culture has these, that are used as justifications for how this particular therapy can and should work. And I would argue that this is an example of low biologic plausibility. I don't think that these ideas are consistent with science, even as metaphors, much less when taken literally. Now, the challenge with acupuncture is that there are other ways of talking about how it could work. There are other kinds of biological rationales that are used for this. And people talk about endogenous opioids or nerve stimulation or various sorts of peripheral nervous system modulation. There are lots of ways that people talk about acupuncture in a biomedical model that doesn't rely on some of the traditional Chinese medicine metaphors that originated the practice. And there are textbooks and articles that talk about specifically this scientific way of looking at acupuncture. And there's no question that when you stick needles in a living animal, things happen, right? You stimulate nerves, you get the release of potentially pain relieving chemicals. You have all kinds of clearly measurable effects, right? I will point out a couple of things. One is that the folks that are most prominently promoting this are often the same people who are practicing and promoting the traditional metaphorical approach to acupuncture. So in some ways, this is a post hoc rationalization for something that you already believe is true, but that you need a scientific explanation for in order to convince other people who don't share your philosophical alignment. And that potentially introduces some bias worth thinking about. The other thing I think that is worth thinking about is that while it is absolutely true that needling has physiologic effects that are real and measurable, it's not entirely always clear if it matters where you put the needles. There have been a lot of studies trying to say, are there particular predictable points at which we can all agree that needling has certain effects? It's been very hard to prove that in the literature. And do the effects of this therapy, are they consistent? Are they predictable? Are they meaningful? And I've often made the point that you can hit your thumb with a hammer and also have pain chemicals released and have nerve modulation. No one thinks that's a biomedical therapy. So we have to be a little careful about saying that, yes, in fact, things are happening here, but we need to demonstrate that they are consistent and predictable and meaningful. And I could do hours and hours and hours of discussion about whether that's true or not. But from a could it work point of view, I think we can have at best moderate confidence in the biomedical explanation for acupuncture. I don't think the jury is entirely out yet on whether those things are true. Now, from a might it work point of view, obviously there's tons and tons of preclinical literature and tons of human literature, and that's mostly what we rely on. This is just a study looking at, are there differences in skin temperature following, needling in an arthritic dog, and could that potentially be modulating inflammation at the site of an arthritic joint? And you can certainly find effects like that. Whether they meet that threshold of consistent, predictable, and meaningful is a little harder to say. So again, if we want to use the evidence that we have in the most effective way, we start with this highest level, this synthetic evidence, systematic reviews. And if you go to the human literature in acupuncture, there are many studies. We've been studying this for at least 50 years in the West and all over. The clinical practice guidelines from the American College of Rheumatology has looked at this and said there are lots and lots of studies, but we're still not really sure. It's really hard to tell because it's really hard to blind therapists effectively. There's a lot of debate about whether sham points or sham needles are the most effective way to do blinded studies. The literature is enormous and a little problematic, right? So even though it's enormous, we can't necessarily have that level of confidence. Now, you can go and find lots and lots of systematic reviews that say that acupuncture is absolutely beneficial, that the literature supports it, there's no question about it. I'm just going to introduce one more little doubt point, hopefully, for you, which is that a lot of those reviews are themselves problematic. This is an example of one, for example, that's been retracted. And the systematic review was retracted because of systematic manipulation of the publication process. Now, that's just a single example. But what I will say is that there is a general problem with the acupuncture literature. A big part of that problem is that a lot of it stems from places where there is a bias towards publishing positive results. To be fair, there's a bias everywhere towards publishing positive results. But this is a study from the late 90s looking specifically at particular countries where a lot of the acupuncture literature is published and finding that from the 1960s through the mid-1990s at least, no trial published for any therapy in China was negative, and almost no therapies, no study, almost all the acupuncture studies were positive. So there's a little bit of a red flag, and that was a long time ago. So we can go through the literature and say, is that still true? And there are a lot of reviews of the systematic review literature that say, yeah, we're getting better, but we're still having problems. This one, for example, from just about 10 years ago, found that still almost 100% of the studies are positive. So nobody is publishing negative studies, which makes a little bit of concern. This is just a few years ago looking at the methodological review of the trials and still found pretty significant methodological issues. Overall, I think this is one of those situations where the volume of the literature makes it really hard to recognize that the literature is actually problematic. And in full disclosure, I took Dr. Robinson's acupuncture course. I practiced acupuncture for a couple of years for reasons which I'll talk about in a second. But I spent a lot of time reading this literature, and I started out from a place of fairly high level of confidence and ended up in a place with a fairly low level of confidence in this literature. In veterinary medicine, we don't have very many studies at all. This is a review from almost 18 years ago now, and they really couldn't make a decision because there just weren't that many studies. The more recent reviews are still finding that there isn't a whole lot of clinical trial evidence, and what it is fairly weak. This was a study using a post-OVH model, and all they could say was that the dogs that got acupuncture needed a whole lot more rescue analgesia than the dogs that got NSAIDs. So at least we shouldn't be using it probably as a first-line therapy. The most recent research I could find was this systematic review from 2024, from just this year, which basically says we still don't know. And it's the same thing we say in human literature, right? We have hundreds and hundreds, maybe thousands of studies, and it's been really hard to prove that it's actually consistently, predictably, meaningfully effective. So I think that's a different kind of warning sign than we might have had with, for example, tramadol or gabapentin. I think what we should say is we're not sure, and it worries me that after all the effort we've put into this, we're not sure. It worries me partly because it's widely popular. This survey found that 20% of veterinary schools in the United States use acupuncture in their clinics. So there is a general assumption that it is effective, and I don't think the literature really supports that. Since anecdotes are compelling, even though they are not probative, I'm going to give you an anecdote. And I know I'm coming up on my time, so I promise I will try to talk faster. Not that anyone wants that. Titan was a dog I saw quite a few years ago now. The male neutered Rottweiler had osteosarcoma in the right humerus. And the client, in general, was not a fan of conventional medical treatment. She went to see a traditional Chinese medicine vet in our area to be treated. But she did eventually come to me to talk about the options for Titan because she was a good person who genuinely wanted to make sure she did everything possible for her pet. And even though she was very skeptical of the kinds of things that I, as a conventional veterinarian, offer, she wanted to have a conversation. And we had a conversation, and I had to say very honestly, I think the things that I have to offer, things like amputation and radiation and chemotherapy, are not things that you're going to want. And realistically, they're not things that are stunningly effective for this disease. I don't have a lot of definitive therapies to offer you. What I did say was, your dog's obviously in a lot of pain. He won't put the leg down. He cries when you touch it. He's clearly uncomfortable. And I do think we could do more to control your dog's pain. And I know that you're concerned about drugs, and we can talk about the risks and the benefits, but I think that's kind of where we might be able to help you. And the response, was not what I expected. The woman, as I mentioned, had been using Chinese medicine, mostly acupuncture and herbs, and also some homeopathy. And she was stunned that I thought that her dog was in pain, because she said to me, no, I mean, at the beginning, he was quite uncomfortable, but I started using these therapies and he just got dramatically better. This, I think, shows you the power of cognitive dissonance. The fact that this is a very intelligent, very compassionate, caring woman who really could not see that her dog was still in pain. Because to see that would mean that the therapies she had chosen were not effective and that she was not doing the best possible care for her pet. And I think that just is a reminder to us that none of us are immune to this amazing ability of the human brain to filter out evidence in a way that supports and is consistent with our beliefs. And that's why I think we really need to rely on science as much as we can. So what should we be doing? We should pay attention to the evidence. We should understand the strengths and weaknesses, and we should try to follow the evidence as best we can. I think this is a useful way of kind of organizing the evidence to help you when you're looking at a particular therapy. I think that in the perfect world, we'd all have just systematic reviews and clinical practice guidelines to rely on, and then we could stop there, but that's not the world we live in. I think we should do the best we can to assess things objectively and be mindful of the placebo effects that we and our clients are vulnerable to. I think we have to accept the hard truth that our experience is not as reliable as it is compelling, and that often our really deeply held beliefs are going to turn out to be wrong, and we need to be, able to accept that. And I think we need to communicate honestly with our clients, share the uncertainty, talk about the urgency to treat and the balance between the two, and help them to make decisions that are informed. And this was the slide that I was asked to think about from an ethical point of view. Ethically, I think evidence-based medicine is the best way that we have to determine safety and efficacy when we have it available. I think our personal experiences are really unreliable, even though they mean a lot to us. And I think we need to acknowledge that. Placebo effects are very common, and they can be really significant. In the case of Titan, they denied this dog some really important pain therapy. And ultimately, I think if our treatments don't work, that's bad for our patients. It's bad for them because it hurts them. They don't get therapies that they need. It's bad for them because we mislead their owners. We're telling them things that aren't true. And I think fundamentally, it's unethical to offer therapies that don't work. And yet I think we do all the time for reasons which are genuine and understandable, but unfortunate. Evidence-based medicine can help. So I think if we use this method, I think we're going to do a better job, and I encourage everyone to try. And at that, I'm happy to answer any questions.
Thank you so much, Brennan. That was a fantastic talk. Lots of people agreeing in the chat box, saying that really thought-provoking. You just laid it out really well, I think. Like the way your could it, might it, does it work approach, I think is actually a really good thing that we could take away to use day to day. Because I don't think I necessarily think of splitting the data and the evidence that we have in that way. So that's really helpful. And, we've talked a lot about sort of dogs, but I do a lot of work with exotics. And then when you come to non-traditional companion animals and what works for pain relief, it's even more of a minefield in terms of what we, know what we've got data for. So yeah, thank you very much. We have had a few questions. So The first question that we have is a concern about evidence-based veterinary medicine, basically saying that while recognizing that it is incredibly important, they struggle with basically researching and doing studies on healthy animals. And do you have any philosophical advice to help them with their ethical dilemma?
Yeah, it is always a problem, and certainly this comes up in human medicine as well. It is difficult to offer a research study with the potential of being on a placebo or the potential of being on a therapy, that we don't know for sure if it's safe or if it works, when you have therapies that you already know are safe and effective. Part of the problem there is that I think the way that we already know our therapies are safe and effective is unreliable a lot of the time. And so people will say, it's not ethical to study this because I already know that it works. And I think that's a problem we need to work on. We need to work on awareness of the fact that we don't already know that it works if we haven't done those studies. I do think that I've been involved in this longevity business for a few years now, and we're starting a few clinical studies. And I am overwhelmed by the enthusiasm of pet owners for participating in clinical research, because obviously a large part of what they want is they want things to help their own pets. But a lot of what they want is they want to make a contribution to help the industry as a whole, the veterinary, the other patients out there. And I think that when we talk to people about the potential risks of research, because there are research risks, I think we also have to talk about the benefits and how huge those are. And if we can imagine a world in which we had the evidence that we need to make these decisions and to offer really effective therapies and to avoid things that are not effective, we'd be doing a whole lot of good, and we'd really be improving animal welfare. So I think that there is maybe a sacrifice to be made, but I think on behalf, at least of their pets, a lot of owners are really eager to make that with, appropriate safeguards. And I feel like in the long term, it's the right thing to do. The better evidence we have, the better care we provide, and that's why we're here.
Brilliant, thank you. I hope that helps the person who asked that question. Um, Time for maybe one more question, and then we'll probably have to wrap things up for the evening. Question: how do you tackle discussions with caregivers that have very strong beliefs in known non-effective interventions? Bringing up the subject with them can be intimidating.
Absolutely, and I think that that's where communication is really important. Anyone who is being dismissive or condemning people for these things, I think, is missing an opportunity to be, first of all, just a compassionate person, but also to communicate effectively. And so I think we have to understand that a commitment to a therapy that probably isn't effective is not a sign of stupidity, is not a sign of lack of compassion. It's a sign that you're dealing with a human being that has a human brain that functions the same way that my brain and your brain function. We end up in beliefs that we can't get out of for reasons which are perfectly understandable and largely universal across people. So I think you have to start with building that relationship, with starting with the common ground. You are here because you want to help your pet. I am here because I want to help your pet. Let's see what I think your pet's needs are, what you think they are. Let's align those perspectives as best we can. And then, I often say to people, you are paying me for my advice. I'm obligated to give it to you. You're not obligated to take it, but I have to give it to you. So if I have to tell you, I don't think this is a good thing for your pet, that's what you're paying me for. And I wouldn't be honest if I weren't doing that. And I think also, you can agree to disagree with people and work with them within the limits they set. As I mentioned, I offered acupuncture for a couple of years. I did so not because I was powerfully convinced that it worked. I still had more uncertainty than I have now about the effectiveness of it, but largely because the folks in our area who offered it were very extreme in their sort of anti-science approach. They immediately took everybody off their conventional medications and diets and vaccines and went, absolutely in the opposite direction. And I thought that was harmful. So I said to people, look, I'm happy to do this for you. I think the risks are low. I don't think it's a particularly problematic therapy in the sense of being dangerous. And I'm not sure if it helps or not. But if you are willing to work with me to take some weight off your dog and continue taking their pain medications and keep checking their blood work and all of those things, I'm happy to offer this for you. And, we can disagree on whether we think it's helping or not. And I think there are ways to work with people that are not either my way or the highway, or sure, whatever you want, I don't care. I think there's a middle ground, but it involves cautious communication and the building of relationships over time. And fortunately, I think vets are pretty good at that because we do that all day long.
Oh, perfect. Thank you, Brennan. I think your talk is also, as well as encouraging us to be skeptical, is also encouraging us to be more open-minded as well, which I think is actually, you know, being more open-minded when we're having those chats with our pet caregivers. You know, we need to have that open line of communication and not shut them down, so that we can get the best results, because ultimately we all want the same thing. But yeah, thank you so much. I think we'll need to bring it to a close there, because it's getting to the sort of the end of the conference. Was there any sort of last points that you wanted to make before I invite Paul back?
No. I mean, I'm happy to take questions offline. I mean, obviously, I'm very passionate about this, and I think there are some misunderstandings about what skepticism and what evidence-based medicine really mean, and hopefully we've undermined those a little bit. But I hope we can continue the conversation in some way. Thanks for having me here.
Thank you, Brennan. I'm sure we can sort of gather all the questions that we didn't get through and put them to you at later points, sort of after the symposium. We can come up with something. I'll hand over to Paul and Hannah for our closing for the evening.
Can I just say, Brennan, I love you. Amazing. Freaking great talk. As I just expected. And Paul was like, he's such a good communicator. I was like, I know.
Yeah, I really enjoyed that. Thanks, Brennan.
Yeah, a lot of love in the
my
chat
pleasure.
before the talk.
Cool. So we're coming to the end. Oh my God. 2 days down, one more to go. It's been an incredible day. It started how many hours ago? 14 hours ago. And we've got one more day to go. So thank you very much for everybody that's attended. We've had a consistent viewing all throughout the day, 300, 400, etc. And that doesn't count all the people in the lobby. We expect to see you all back tomorrow. Bring your coffees. We start UK time 8 a.m. and it is as jam-packed as it was today. Can you think of a couple of the people? I know I can, Paul. Do you want to just tantalize?
Yeah, I mean, we start the day really strongly, don't we, with Sarah Heath and Claire Rusbridge, which will be a fascinating look at neuropathic pain. We have chronic pain in cats features quite well tomorrow, which will be a really good topic.
Yep.
Compassion and care burden. So there's loads of different, there's loads of variety in the topics as well tomorrow. Don't forget as well, there is the exhibitors area. There's lots of resources in there that you can take a look at. We've sent out the links to the virtual event bag. And we're about to send out an email just asking for some feedback on today's talks and the event in general. If you could give us some feedback, that would be greatly appreciated.
Perfect. So thank you, Brennan. Thank you all the speakers for today. Thank you all the delegates for your lovely messages. What I have really, really enjoyed seeing is such lovely messaging amongst yourselves. You've got each other's back. And that's what this is about, is that it's a collective team approach. The interdisciplinary approach is that we all work together. So seeing the conversations and sharing of knowledge and supporting each other is fantastic. Keep it up and we will see you tomorrow morning. Take care, guys.
Thanks, everyone. Bye.